Hi, my name is Rachel Darby. I'm a general dentist and I work in Buckinghamshire. And about 2 years ago, or quite close to 2 years ago now, my husband and I bought our very first practice, Chapel Dental, in Flackwell Heath. So as I said, I'm a general dentist, but I really like the restorative aspects of dentistry. I like doing fillings, crowns, bridges, root canals as well. That's my main passion. I think a screw up is when it just doesn't go perfectly. And to be honest, I've probably spent my entire career screwing up. Now, screwing up doesn't mean that the patient's going to die or that it's going to fail next week. The screw up could be you didn't get to remove the flash, the contact wasn't right, the morphology wasn't looking great, your bonding protocol didn't go right. And I think composite filling, especially class 2 posterior composites, they're one of the hardest things to do, but yet it's something we do day in, day out, and we're expected to be amazing at it. But so much can go wrong in the process. So it's a little bit tongue-in-cheek. I think I've spent I've qualified 14 years now. I know I don't look it, but 14 years. And still I probably screw up every day. So it's a bit tongue-in-cheek, and it's just going, I think these are the main areas that we can mess up in and just how to minimize that. Some days things will go brilliantly and perfectly and the composite gods will shine down, but more often than not, we can see 1 or 2 things that we think, oh, I could have improved on that, or that didn't go right. I think there's 2 aspects to that. There's the clinical side, and when we look at the clinical side, we could think isolation. Have we chosen the right matrix band as well for the job? Have we removed all of the decay? Have we got the right cavity prep? Are etching and bonding protocols correct? Is the placement correct? Are we doing it incrementally under all of these amazing conditions such as isolation? Is the occlusion right? So if you've got all of those correct, then on the other hand, you've got the patient. There's somebody attached to the end of that tooth and you have to manage the patient, somebody who could hate being numbed up. They don't want the rubber dam on. So you have to manage their feelings and their emotions as well as do this excellent clinical work. So there's 2 aspects to it. I think we probably see it more times than we care to admit, and I know I definitely see it sometimes, and it could just be something so minimal that the contact point wasn't just quite right, or it was in the wrong place. So the contact point ideally shouldn't be at the very top of the filling, it should be further down in the middle third of it. So is it too high? Is there a little bit of a gap? Was my morphology not looking quite right? Does the patient even care about morphology? They want something that's going to last. Or you take an x-ray and just go, is there a little bit of a gap there? You're looking at all of these black and white lines, you're thinking, oh, is there something? But you might not see that till 2 years later when you're next taking the x-rays. Is there a bit of flash, and then has that taken up the staining? There's so many things that could happen there, but at the end of the day, is there any decay around it? Is the patient complaining of any pains or any symptoms? Is it working and is it functional? I think that determines the success of it, rather than that little 1% that we might not be incredibly happy with. Well, I think decay is a key point to the failure. That more is coming into the bonding and the etching and bonding protocol with it. But if it's letting in decay, yes, that would be a failure. If there's symptoms, if there's sensitivity with it, something has gone wrong, it's causing the patient's problems and it needs to be addressed. If the contact point is too open and it's letting in food trap, that could then let decay into it as well. Well, I think it all starts with communication with the patient to make sure that they're going to accept what's going to come ahead, the local anaesthetic, being in the chair for a certain amount of time. Like, let's face it, I cannot do a good filling in 5 minutes. I think if you're going to try to do that, well, hats off to if you can manage a really good quality filling. I definitely couldn't. So communication with the patient, we want to think about isolation, and for me that is rubber dam. It's not cotton wool rolls and a load of suction. So isolation, we want to ensure correct removal of decay. If it's getting deep, are we thinking about removing certain parts of the decay in order to let the rest remineralize? If it's particularly deep, are we going to pulp cap it or not? So having those protocols in place to make sure that there's no sharp edges, nice rounded cavity preparations. We're going to then sandblast to remove the aprismatic enamel. Then we're going to start our etching and bonding protocol, which, absolute spoiler alert, just follow the instructions. There's been millions and millions of pounds on it don't then decide to do something different. You know, think it's like IKEA furniture, follow the instructions, don't go off on your own and it will be right. So that's the big spoiler, just do that. For the etching and bonding protocol, correct matrix band selection, then incrementally place the composite, cure it under glycerine as well, and then check the occlusion at the end of it and pray to the composite gods that everything went okay. It's something I've gathered from courses. I've been on many courses. I'm definitely not a composite master. I think I've learned from a lot of other people who are. So all of it is basically taken from them, but I think that's, you know, the same. Composite hasn't changed throughout the years, the last 10 years. We've still got the protocols and we have to follow that aspect of it. You can't skip a step at it. It's a little bit like baking a cake. Not that I ever bake a cake, but you have to follow the procedures. You can't add something early, something late, stick it in the oven and then try to add a bit more to it. It has to be done in the steps. If we're doing treatment, we need to phase treatment. So we always need to get rid of decay. We need to get rid of anything that's suboptimal, where the composite comes in, and that will stabilize the mouth. And then we can carry on and do Invisalign afterwards. Health and function should always be paramount, especially before we're doing anything cosmetic. But there have been times where I would say, if I'm doing a crown prep and the filling is a bit suboptimal, like an old amalgam that's going to be beside the crown, it's a bit ditched, a bit suboptimal, I would prep the tooth and do the composite at the same time with it. What I hope that people take away is just some tips and tricks that they can bring back to clinic on Monday morning and start being able to utilize. I suppose in a way it's refresher, it's relearning aspects that we already know, but we maybe have forgotten about it because we're quite busy. Hopefully people will take away something new with it, you know, a refresher of the bonding protocol, maybe a new idea about type of matrix bands or cavity preparation. And it's also going to be a bit tongue-in-cheek as well. Oh, there are going to be some pictures of what I deem very sexy morphology. So I'm doing a course next year. Dates are to be confirmed, but that's actually going to be in Northern Ireland. And if you're interested in it, you can go on to the NIMDTA, which is the Northern Ireland Medical Dental Training Agency. So they'll have all of the details there with it. But if you're in the UK or Great Britain and you want to get in contact with me, then just contact me, probably the easiest on Instagram at Dr. Rachel Darby.